Okay, hey y'all. So today we're going to go over respiratory and HEENT, and I'm pretty sure that means head, eyes, ears, neck, and throat. So we're going to go over all the respiratory disorders and then like the other ones as well. And like always, I'm going to upload the PowerPoint for you guys to use so you guys can like study that and stuff. And then if you guys could please use the attendance link, so please scan the QR code. That would be really helpful. Even if you're just watching the recording, please scan the QR code. So here's my contact information. Like always, you can either contact me via Facebook Messenger, or if you don't have Facebook, you can also contact me through my email. I answer both pretty quickly, so either or is perfectly fine. If you have any questions or anything that I like said wrong, or like if the information is not matching up with like Platt or anything, just contact me, let me know. So some important concepts for respiratory, and this is like a really big thing to remember. So children are more likely to experience respiratory arrest than cardiac arrest, which is like super huge. So remember that their hearts are young and strong, but their lungs are small and vulnerable. So if you find a child is arrested, think about their airway first. So with children, airway is like your first concern. So the goal of managing respiratory emergencies, so you want to maximize their oxygen delivery, correct their ABG imbalances, treat the underlying cause, minimize organ failure, and then anticipate any complications that could occur from respiratory emergencies. So hypoxia, and I'm gonna go over these signs again later when we start talking about respiratory distress, but this is just like a quick overview, and it's a really good way to remember it. So for hypoxia, remember FINES, which are the signs and symptoms for pediatrics. So F is for feeding difficulty, I is for inspiratory stridor, N is for nasal flares or nares flaring, E is for expiratory grunting, and then C is for sternal retractions. And then these are the type of retractions that can happen in the sternum. So supraclavicular, suprasternal, intercostal, substernal, and subcostal. And again, I'm going to talk about this again towards the end of the PowerPoint when we start talking about respiratory distress, but this is just like a good thing to help you remember the signs and symptoms for it. So make sure you know those signs and know the different types of retractions as well. So seasonal variations. So some things are more common during winter and spring. So mycoplasma infections are more common in fall and winter. Asthmatic bronchitis is more frequent in cold weather, and then RSV, or respiratory syncytial virus. I'm pretty sure I butchered that, but RSV is considered a winter and spring type of disease. So nursing interventions, just a general overview for like respiratory. So you want to ease the respiratory effort, also have that fever management, promote rest and comfort, infection control, which is really big for cystic fibrosis, which we're going to get into later, promote hydration and nutrition, family support and teaching, prevent the spread of infection, and provide support and plan for home care. So yeah, these are just kind of like the general nursing interventions for just respiratory. And then we're going to get like deeper into them. And then here's some more, and we'll go over the specifics for like each disease or disorder when we get to them. So you want to raise the head of bed, provide humidified air, monitor their vitals and respiratory quality and how they're breathing. So like if they're having really labored breathing, you want to monitor that. If they're having shallow breathing, want to monitor that, you know, just things like that. You want to suction their airway if that's needed. You can provide chest percussion and physiotherapy, encourage deep breathing, administer bronchodilators and any other meds prescribed by the PCP. You want to initiate the aspiration precautions for certain patients, tripod positioning, respiratory monitoring and surveillance, like we said earlier, oxygen therapy, airway suctioning, vital sign monitoring again, cough enhancement, anxiety reduction, because remember, anxiety is contagious, and hand washing is a big thing as well. And then here are the different disorders. So we have the uppers versus the lowers, and make sure you know which ones are upper disorders and make sure you know which ones are lower so you don't get them confused. So upper, we have nasopharyngitis, strep A pharyngitis, tonsillitis, peritonsillar abscess, influenza, otitis media, otitis externa, croup, because I'm not even going to attempt to pronounce that right now, acute laryngitis, acute spasmodic laryngitis, acute epiglottitis, and then bacterial tracheitis for the uppers. And then for the lowers, we have bronchiolitis, RSV, acute bronchitis, pneumonias, asthma, and pertussis. So now we're going to get into the upper respiratory disorders. So nasopharyngitis, it's also known as a common cold. So they'll be febrile for 2 to 3 days. Then they'll have a runny nose for about 7 to 14 days, and then they can cough up to 3 weeks, which is normal. So it's not a sinus infection unless the symptoms last for more than 10 days. And that's important for you guys to remember. So the common cold isn't considered a sinus infection, again, unless the symptoms last more than 10 days. And then nasopharyngitis can be caused by numerous viruses. So fever, it varies with how old the child is. So temps will run higher in the afternoon and the evening. And then they could be irritable, restless. They could have a decreased appetite, decreased fluid intake. They could also have some nasal inflammation, vomiting, and diarrhea. So the treatments for the common cold or nasopharyngitis. So over-the-counter cold remedies aren't recommended to use for the common cold because cough and cold meds aren't used in young children. And then they can only be given to 4 to 6-year-old children with the recommendation from their primary healthcare provider. So make sure you guys keep that in mind. And then antihistamines don't work for nasopharyngitis because it's not allergic rhinitis. As far as decongestants, you can't give them to children that are younger than 6, but they're used to shrink swollen nasal passages, and nasal sprays work better than oral meds. Afrin can only be used in children that are older than 6 and can't be used for longer than 3 days. So make sure you remember that as well, that Afrin can't be used for longer than 3 days and they have to be older than 6. We can also use antipyretics for comfort and then cough suppressants for that dry cough. So strep A pharyngitis. So the signs and symptoms, they'll have that sore throat, which is like a really big sign and symptom. I'm going to go ahead and bold it for you guys and make it red. Okay, so yeah, so sore throat is a really big sign and symptom for strep A pharyngitis. They can also have fever, nausea, vomiting, and some stomach pain. So with these patients, they won't have any cough. Unlike nasopharyngitis, they'll have like a dry cough kind of. You might see white spots on their tonsils and their palatal petechiae, but the white spots on the tonsils aren't diagnostic. So even if you do see white spots, it doesn't mean that they have strep. You could also see red sandpaper-like rash on the chest, which indicates that they might have scarlet fever. And that's a chronic complication. So the chronic complications are scarlet fever, which is that red sandpaper rash on their chest. They could also have rheumatic fever. And for rheumatic fever, kind of go back to your cardiac notes and like review the signs and symptoms of rheumatic fever. And then they can also have acute glomerulonephritis, which happens 3 weeks after a strep A infection. And I think I went over that last week, but if not, I'm definitely going to go over it during our review session. So the nursing care for strep A pharyngitis. So hydration is like a really big thing with these patients. So you want to assess their hydration and constantly stress fluids for them. Antibiotics. So they'll most likely be taking penicillin. So for penicillin, make sure you know the indications, side effects, teaching, and how long to give penicillin. And it can either be given oral or intramuscular. They can also be taking Augmentin, and diarrhea is the biggest side effect of Augmentin. So for both the meds, make sure you know the indications, side effects, teaching, and how long to give. And also know like the therapeutic like outcome as well. So tonsillitis can either be bacterial or viral, and viral is the most common cause of tonsillitis. So again, for these patients, they'll have that sore throat, which again, I'm going to go ahead and bold it for y'all. and put it in red. They can also have enlarged cervical lymph nodes. They could have difficulty swallowing, so they'll be mouth breathers, and they'll have fever or malaise. So for tonsillitis, the nursing care, if it's bacterial, they'll be given penicillin. If it's viral, you can only do like rest, hydration, cough drops, and then over-the-counter analgesics. They can also have a tonsillectomy. So it's used if they have multiple antibiotic allergies, peritonsillar abscess, which we're going to get into next, or an airway obstruction. So for pre-op, no coding for children under 12. So no coding can be given for any children that are under the age of 12. Post-op, so some things to really look out for post-op are frequent swallowing means it's an early sign and symptom of bleeding. So if you see the child is like constantly swallowing, you need to think in your mind like, hey, they might be having some excess bleeding. You want to position them on their side to help with drainage, no suctioning for these patients, and try to avoid red, purple, and brown liquids because they can be mistaken for blood. So peritonsillar abscess. So it's a complication of tonsillitis, gum disease, infected tooth, anything like that. So the biggest sign and symptom for peritonsillar abscess is that hot potato voice. And I remember this being like a question on the exam. So when you think of peritonsillar abscess, automatically like related to hot potato voice. And I don't know if she showed you guys like a video of it, of how it sounds in class, but if you have time to like look up a video of how hot potato voice sounds, really like look at it and listen to how it sounds because it is kind of interesting. They'll also be really toxic and sick looking. They'll have a sore throat. Their head might lead to one side and they'll have a lump on one side of the neck. Oops. So for mild peritonsillar abscess treatment, they can either have cephalosporin or clindamycin. So you want to recheck their signs and symptoms if they're presenting worse in 24 to 48 hours. And then if it's a more severe case of peritonsillar abscess, then they'll have a tonsillectomy or an IND of the abscess. But the only thing is with the abscess, if it bursts on its own, then the pus can travel to the lungs and it can cause pneumonia. And we're going to get into pneumonia later, but yeah, so that's like a complication of peritonsillar abscess. So if that abscess does burst and like it's not drained properly or whatever, the pus can just travel down to the lungs and then now the child has pneumonia. Oops. So influenza has an abrupt onset. For some of them I didn't put the patho. Yeah, so if you guys need me to put up the patho for these, I can, but I feel like the signs and symptoms and all that stuff is like a little more important. So the signs and symptoms of influenza are cough, sore throat, or like a runny, stuffy nose. And then vomiting and diarrhea is more common in like younger children. So for influenza, the biggest thing to do when you have like a kid that has the flu is they just need to stay home because it's contagious. So you want to have them being properly hydrated, washing their hands, hand sanitizer, analgesics. For the meds, they can take antivirals, but a big thing to remember with the flu in children is no aspirin because it can cause Rye syndrome, which is an inflammation of the brain and liver. So make sure they're not taking any aspirin. And then for the complications, they need to go to the ER if they have a change in level of consciousness, if they're experiencing any respiratory distress, which we'll get into later, cyanosis, chest pain, if their fever is above 104 for more than 3 days, or if they experience seizure. And they need to go to the ER if they have any fever of any kind, if they're under 3 months old. So otitis media is one of those HEENT disorders because it's the ears. So for otitis media, it normally develops at the end of upper respiratory infections, and 3 to 4-year-olds are at the biggest risk for getting otitis media. So some signs and symptoms, they'll have a red bulging TM, erythematous. I'm sorry, y'all know I like butcher these words, but that word, TM, and then they could be febrile, but they're not always febrile. A big thing with otitis media is like that redness in their like TM is not like diagnostic, because they can like, it can turn red from them like crying. So yeah. And then some other risk factors for it are secondhand smoke, and if they have like a history of allergies. The treatment, so they can be given oral antibiotics, amoxicillin, and they'll be given a high dose of that. They can also have benzocaine eardrops, which can be used for topical pain relief. They might also have their tympanostomy tubes, so they can drain the fluid in the middle of the ear. A big thing is breastfed infants have less OM than bottle-fed infants. So that's like a good thing to remember. That's why they want them to breastfeed for a while, like the first 6 months, like strictly breastfeeding. And then chronic OM can cause hearing deficits. So it can be permanent if it's not treated. So for teaching, what you want to teach these patients is for prevention, have them upright when feeding to avoid any reflux, no smoking around the kids because secondhand smoke is a risk factor. Make sure they know the signs and symptoms of ear infections, make sure they're up to date with their immunizations, and then again, encourage that breastfeeding for the first 6 months because breastfed infants have less otitis media than bottle-fed infants. So otitis externa. So it's infections of the external ear canal, and this is also called swimmer's ear. And otitis externa is super, super painful. So that's another thing you need to remember. So know the other name. So otitis media can also be called swimmer's ear, and that it's really painful. So some signs and symptoms, they could have like boogers in their ear canal. So it's just like a lot of mucus clogging the ear canal, and it'll be really red and raw. The treatment, so you want to give them antibiotic eardrops. And then for prevention, they can make their own homemade like swimmer eardrops. So it'll be like a mix of half white vinegar and half hydrogen peroxide. And then for the nursing care, you can do analgesics, warm packets, and no Q-tips for otitis externa. And then you also want to teach how to prevent it. So make sure you know the preventative care for otitis externa. Okay, so croup is like a combination of like 3 things. So acute laryngotracheobronchitis. So it's inflammation of the larynx, which is where that larynx comes from. Then the trachea, which is the tracheo, and then the bronchi, which is the bronchitis. So it's like a combination of 3 things. So some signs and symptoms of croup is hoarseness, and then this barking seal-like cough is like a big sign of croup. So I'm gonna go ahead and bold and make that red for y'all. So again, hoarseness, a barking cough or like a seal-like cough, inspiratory stridor. And then they can also have varying degrees of respiratory distress. And again, we're going to get into respiratory distress at the end. So some treatments for croup are the short-acting bronchodilators, and make sure you know the different types, steroids, and then the racemic epi, which is like the main thing you'll give for croup, I believe. And it's a nebulized epinephrine. And then you can also do O2, which is brief exposure to cool night air, or like they can take like a cool shower. But the racemic epi is like the main treatment for croup. So this is like how they'll look. I like these pictures a lot because, you know, it's like a good way to visualize it. So for croup, they'll have a slow onset, that barking seal-like cough, the inspiratory stridor, it occurs at night. It's higher in the fall and winter, and then they could progress to that hypoxic state. So remember, make sure you know the FINDS acronym and like what the signs and symptoms of hypoxia are in pediatrics. And they could also have a slight temp. And then for croup, make sure you know the age group that it's most likely to occur in. And then they could be restless and retractions. So again, like that seal bark-like cough is like the main type of sign in stridor. So acute laryngitis, it's more common in older children. So make sure you know the specific age for like when it's most common for kids to get acute laryngitis. So some signs and symptoms, they'll be hoarse, so they'll say they're losing their voice. So for this, the main treatment, is just saltwater gargles, tea with honey, and like soothing cough drops, because it's just like they're losing their voice, so their voice is like kind of cracking. And again, make sure you know which age group is more prone to getting acute laryngitis. Acute spasmodic laryngitis, it's like another variation of croup. So it's viral, and it's considered midnight croup because it occurs mainly at night. So the treatment for this is cool air or humidifier, and then to stay calm, because remember, anxiety is contagious. So I feel like that was kind of confusing because I said here, like acute laryngotracheal bronchitis occurs at night, and then acute spasmodic laryngitis also occurs at night. So if she like during lecture didn't specify anything about these two, about the acute spasmodic laryngitis, you can kind of disregard it. I just put it because it was on my review, so I just included it just in case. So acute epiglottitis, it's an emergency. So make sure you know, like, this one is very severe. And I'm gonna go ahead and bold this for you guys. So it's inflammation of the epiglottis, which is caused by bacteria. So it'd be caused by the Haemophilus influenza or Streptococcus pneumoniae. So for the assessments, acute epiglottitis has really, really sudden onset. So they'll experience tachycardia and tachypnea, and they'll have the 4 Ds, which is dysphagia, drooling, dysphonia, and distress. So make sure you remember the 4 Ds for acute epiglottitis. They can also have fever. They'll also have that cherry red sore throat, nasal flaring, and then if they're in the tripod position, that's an emergent symptom. So for acute epiglottitis, it primarily affects children between 2 and 8 years old, and it's considered an emergency because it can obstruct the airways really, really quickly. And then the child, like, since it's such a quick onset, so the child will wake up with a high fever, like out of nowhere, and then they'll have a really bad sore throat, so that cherry red sore throat, and then pain when swallowing. So again, if your child starts to present with these symptoms, it's an emergency because they're on their way to an airway obstruction. So again, I love these pictures because I feel like it's really good for visualizing. So before I get into the treatment, I'm just going to go over this really quickly. So like I said, it's leading to like an airway obstruction. So the airway will be closed. They'll have an increased pulse, so that tachycardia. They'll be restless. They'll have retractions. They'll have increased anxiety, inspiratory stridor, and that drooling. So those 4 Ds. So for acute epiglottitis treatment, you want to maintain a patent airway, and you don't want to stick anything in their mouth or liquor in their mouth because the throat can swell up and close off. Because remember, like, they're on their way to airway obstruction when they're experiencing acute epiglottitis. So you don't want to put anything in their mouth. You want to maintain them on NPO status, give them IV antibiotics and IV fluids, keep them cool, calm, and collected. And then what should be at the bedside? So you want to have endotracheal equipment at the bedside because these kids will most likely be intubated. And then you also don't want to leave the child unattended. So for the nursing care, you want to position them for comfort, decrease their anxiety, because remember, anxiety is contagious. No tongue blade because, again, airway obstruction. Keep suction at the bedside table, and then keep emergency respiratory equipment at the bedside because these kids normally are intubated. And then I wanted to go over like the difference between epiglottitis and croup, so it's not like confused. So for epiglottitis, they'll appear toxic and unwell, but with croup, they'll appear looking fine. Epiglottitis, like I said, is an abrupt onset, so they'll just wake up and like have like that fever. Their throat will be really sore, all that stuff. And then croup has a slower onset. So the fever, they'll have a high fever for epiglottitis, and then croup is moderate. Stridor, they'll have moderate to severe for epiglottitis, and then croup is mild to moderate. For their cough, for epiglottitis, it'll be minimal or absent, and then for croup, remember how I said they have that barky, seal-like sounding cough. Epiglottitis, they're unable to speak. For croup, they have a hoarse voice. And then epiglottitis, they're not able to swallow their secretions. They'll be drooling a lot. So remember those 4Ds. And then croup, they're able to swallow. So I'm just gonna go back a couple slides for the 4Ds because that's really important for you guys to remember for this. So dysphagia, drooling, dysphonia, and distress. So make sure you keep that in mind when you're thinking of acute epiglottitis, and remember that it's an emergency because it can lead to an airway obstruction. So for the last upper respiratory disorder is bacterial tracheitis, which is an infection of the mucosa of the upper trachea. So some signs and symptoms are thick secretions, respiratory distress, stridor, and they could develop life-threatening obstruction or respiratory failure with bacterial tracheitis. So for the treatment, you can give them humidified oxygen, antipyretics, antibiotics, and also keep in mind that these patients might need to be intubated. So bronchiolitis, make sure you know the difference between bronchiolitis and bronchitis because they're not the same thing. So bronchiolitis is viral, so RSV is normally the common cause for it. There's other causes, but RSV is like the most common one. So infants and young kids are susceptible for respiratory distress because of their smaller airways. Remember how I said at the beginning, respiratory arrest is more common than cardiac because their lungs are small. It's usually seen in fall, winter, and spring months. So some signs and symptoms, the early ones, it'll be like a common cold, so like runny nose, fever, coughing, sneezing, things like that. Then late, they'll have poor feeding and the respiratory distress symptoms, so tachypnea, cyanosis, lethargy, and decreased breath sounds. So make sure you know the difference between early symptoms and late. So RSV affects the epithelial cells of the respiratory tract, so the bronchiolar mucosa swells and narrows the airway. So it's an acute viral infection, and so the common cause for RSV is bronchiolitis. So they're not the same, but they're almost kind of similar a little bit. So again, remember for bronchiolitis, the common cause is RSV, but then RSV, the common cause is bronchiolitis. So for RSV, you want to initiate contact and droplet precautions for it. The assessment. So for the initial assessment, they'll have rhinorrhea, pharyngitis, coughing, wheezing, otitis media, or conjunctivitis, or intermittent fever. So as it's progressing, then they'll have an increase in their coughing and wheezing. Then they'll get that fever. Then they'll have tachypnea with retractions. For like infants, they can refuse to nurse or bottle feed, and then they'll have like a lot of secretions. And then once it gets to the severe stage, they'll have tachypnea with like more than 70 breaths per minute. There'll be listlessness. They'll have listlessness. They'll have apneic spells, poor air exchange, poor breath sounds, and cyanosis. And RSV is more prevalent in the months of November and March. So the diagnosis is like a nasal swab, kind of like COVID. It's like, you know how you get COVID tested and they like stick the swab up your nose. It's like the same. So for prevention, you want to give them Synagus, which is for high risk babies, like premature babies and infants with congestive heart disease or congenital heart disease, sorry. And then you also want to avoid contact with sick people, limit childcare, wash hands, avoid touching the face, things like that. And then for the nursing interventions, for uncomplicated cases, you can treat them symptomatically with supplemental O2, fluids, airway and maintenance and meds. So provide oxygen if the infant has poor oxygen stats. You can do periodic suctioning, but no chest physiotherapy for them. You can do fluid per oral, but it might be contraindicated because of the tachypnea, weakness, and fatigue, because remember, like in the progressive stage, they could like refuse bottle feeding, or like they could refuse things by mouth. You want to encourage breastfeeding, avoid tobacco smoke exposure, promote preventative measures like that hand washing, limit childcare, avoid contact with sick people. And then again, for that prevention, so the Synagus for the high risk, infants. So it aids in preventing RSV, but it doesn't always prevent it. But it can make it to where they get, if they get it, it's not as bad. So kind of like the COVID vaccines, like even if you get COVID, you won't like get hospitalized. Sorry. And then again, for prevention, just teach parents to avoid other sick kids. So RSV is not similar to COVID, but like the treatments, like the diagnostic is, and like kind of like the prevention is kind of similar. So bronchitis, and remember how I said, make sure you know the difference between bronchiolitis and bronchitis. So bronchitis is inflammation of the trachea and bronchi, and it can also be called a chest cold. So it's viral. The assessments for it, so they could have fever, and then the biggest assessment is they'll have a dry, hacking, and non-productive cough, which is worse at night. And then they could also get a laryngeal spasm, which is they're coughing so much and they can't get any air in, which will increase their anxiety, which makes it just even worse. So like, that's why anxiety reduction is like a big thing, because again, remember, anxiety is contagious. So the treatment for bronchitis, rest, hydration. So you want to keep encouraging those fluids, saline nose drops, and then antipyretics. So pneumonia, there's viral, atypical, or bacteria. So those are the 3 types of pneumonia. And pneumonia is essentially inflammation of the lungs, or like just fluid in the lungs, you know. So make sure you know like the difference. So some signs and symptoms, they can have chest pain, shortness of breath, coughing with mucus, and then crackles at the lung bases. Treatments, so rest, fluids, and O2, albuterol, MD, or a nebulizer, and they can have 4 to 12 puffs. They can also do prednisone. And then make sure for pneumonia, especially for pediatric patients, you're doing your assessments every 2 hours. So respiratory rate, breath sounds, vital signs, all those good things. Make sure you're constantly doing those for children that have pneumonia, so we can see if they're like getting better or getting worse. So pertussis, it's viral and it's most common in spring and summertime. The signs and symptoms, so they'll have, for early, it's like a common cold, but the biggest sign for pertussis is like a whooping cough. So it's uninterrupted coughing and whooping sound on inspiration. And they can also have vomiting, apnea, gasping, and cyanosis. So the treatment for it is prevention with the vaccine. So they'll get the DTaP, and then they can have a maintenance or a booster, the Tdap, I believe, between like 11 and 64. And yeah, I'm pretty sure it's 1 booster shot of Tdap, but if I'm wrong, just correct me. So now we're going to get into asthma. So asthma is a chronic inflammatory disorder of the airways, which essentially just causes the airways to narrow. So some triggers are cold air, smoke, secondary smoke, allergens, exercise, viral infection, stress, or medications. So assessments, breath stacking, so they can't get air in and out, which causes a lot of air to be stuck in the lungs. They can also have the allergic triad, which is asthma, allergies, and eczema. Wheezing is a hallmark sign. And then they can also have dry cough, shortness of breath, chest tightness, retractions, use of accessory muscles, and restlessness. And then a big thing with asthma, so if they begin to have absent breath sounds or decreased wheezing with tachypnea, it means they're having an impending respiratory failure. So for the treatment, for long-term control meds, they can take inhaled corticosteroids and long-acting beta-2 agonists. So make sure you know your inhaled corticosteroids and your beta-2 agonists for asthma. So inhaled corticosteroids are the most effective and work better when combined with long-acting beta-2 agonists, so like Advair. And then also they're quick relief meds, so anticholinergics like ipratropium bromide, which relieves spasm. Then they can take the short-acting beta-2 agonists like albuterol, which also relieves spasm, and then systemic corticosteroids, which relieve inflammation. And then for teaching with parents and with older kids, make sure they know the difference between the maintenance inhaler and the rescue inhaler and when each is like used. So they're not confusing them. So when they're having an asthma attack, make sure they know to take their rescue inhaler and not take the maintenance. So for an acute asthma exacerbation, so respiratory distress continues despite vigorous therapeutic measures. So for the ER treatment, so they'll give them bronchodilators, so a continuous nebulized short-acting beta-2 agonist. They can also take systemic glucocorticoids, so like oral prednisone or dexamethasone. But the only thing with those is they take 4 to 8 hours to kick in. So keep in mind if that is administered. And then for the more moderate or severe cases, they'll have anticholinergics, so that ipratropium bromide with the beta-2 agonist and the systemic glucocorticoids. So if they're not responsive to the above, then we'll add IV mag sulfate. And then if it's severe and it's not responsive or unable to nebulize the beta-2 agonist, then they'll give intramuscular or sub-Q epinephrine and either intramuscular or IV dexamethasone. So Heliox, it's not recommended and it's better to intubate. And then we'll give IV ketamine for anesthesia prior to intubation. So yeah, so just know like the treatments for like each emergent situation. So if it's like mildly emergent, then we'll do this part right here. But then like the more severe it gets, the more that we have to add. So just make sure you know like what to start off with for the moderate to severe. And then if they're not responding to that, make sure you know to add mag sulfate. And then if they're still not responding to that, make sure you know the next step. And then if they're still not responding to that, then make sure you know that we're giving ketamine to for the anesthetic for intubation. So now we're going to get into signs of respiratory distress in asthma patients. So if they remain sitting upright and refuse to lie down, that's bad. If they're agitated, or if an agitated child suddenly becomes really quiet, that's also really bad. So those are like the two main things for respiratory distress in asthma patients. So if they're sitting upright and they don't want to lay down, that means they can't get any air when they're laying down, and like that's not good. And then again, if they just get really quiet, if they were really agitated like 30 seconds ago, then all of a sudden they just stop and they're just super silent, you need to be alert, like, okay, something's going on. Like you need to be thinking my child is going like further into respiratory distress. They can also have diaphoresis, so that's sweating. They could be pale. They'll have nasal flaring and they'll be struggling to breathe. And they could also have decreased breath sounds and no wheezing. So once those, because remember how I said like on the first slide, if they have absent breath sounds and decreased wheezing with tachypnea, it means they're having like impending respiratory failure. So here they're already like in distress and we don't want them to go into failure. So for these, I'm going to go ahead and bold them because these are like really important for respiratory distress. So some signs and symptoms of respiratory distress are that restlessness, tachycardia, and tachypnea. And then here is like the hypoxia signs and symptoms and the retractions that I talked about at the beginning of the PowerPoint. So the retractions, make sure you know the difference. Make sure you know the different types of retractions that they can have. So like substernal, suprasternal, intercostal, all of those. And remember, I put a picture of it at the beginning. And then the fines, again, remember those signs and symptoms, it's really going to help you. So feeding difficulty, inspiratory stridor, nares flaring, expiratory grunting, and then sternal retractions. So make sure. I don't know how many times I can emphasize, like, make sure you know the fines, like signs and symptoms. It's really going to help you out when identifying, like, if your child is going into respiratory distress. Okay, so if a kid appears with respiratory distress, the first thing you want to do is find somebody to help you, and then give them 100% oxygen with a non-rebreather mask. But again, like I was saying, knowing the FINES acronym is really going to help you with determining whether or not your child is going into respiratory distress and knowing like those signs and symptoms. And then cystic fibrosis. So it's an autosomal recessive genetic disease. So it's a chronic multi-system disorder characterized by exocrine gland dysfunction. So the mucus produced by the exocrine gland is super thick. The exocrine gland is super thick, sorry. So it's progressive and it's an incurable disorder. So respiratory failure is a really common cause of death with these patients. The number one goal is to prevent infection, like I said earlier in the PowerPoint, because infection reduces life expectancy. And the number two goal is to provide adequate nutrition. So cystic fibrosis patients will have respiratory problems. So the mucus plugs lung tissues, which leads to inflammation, infection, and scar tissue, which then leads to airway obstruction, which leads to respiratory failure. They can also have digestive tract problems and pancreatic dysfunction. And then again, cystic fibrosis is just like an increase in thick, sticky mucus, which is because of an abnormal salt balance. So when you're thinking of cystic fibrosis, just remember that they have a really thick mucus and that we want to prevent infection because it reduces their life expectancy, and respiratory failure is a common cause of their death for patients with CF. So assessments for the respiratory system for cystic fibrosis, they'll have multiple respiratory infections without a break in between. They'll also have wheezing, coughing, fever, shortness of breath, cyanosis, barrel chest, clubbing of the fingers and toes, and salty kiss, which I'm pretty sure she'll put on your test. So make sure you remember like cystic fibrosis, salty kiss, cystic fibrosis, salty kiss. Because I'm like 99% sure she asked us about that. And then for pancreas assessment, so they'll have the meconium ileus at birth, failure to thrive, and they'll have poor weight gain, and they'll have steatorrhea, which is fat stools because protein and fat aren't absorbed due to pancreatic insufficiency. So remember how I said that they have pancreatic dysfunction? That's why. So I'm just gonna, before I get into the diagnostics really quick, I just wanna go over this picture. Just the symptoms part. I'm not gonna like talk about this right here. So for symptoms, they can have fatigue, chronic cough, recurrent URI, so upper respiratory infection. They'll have that thick, sticky mucus. So like you see here, they'll have a decreased absorption of vitamins and enzymes. They can have abdominal distension, a decrease in digestive enzymes. They can have rectal prolapse, and then they'll have those fat, stinky stools because nothing's like being absorbed properly. So for cystic fibrosis, for diagnostic purposes, we want to do the early newborn screening, DNA testing, and then the confirmation for CF is immunoreactive trypsinogen or IRT. And then they'll also do sweat chloride testing, and their results will be high. So for cystic fibrosis, if it's greater than 60, that means that they have it. And then some nursing interventions for CF. So for respiratory, airway clearance treatments to loosen and clear lung mucus, reduce infections, and improve their breathing. You also want to do mucus thinning meds via nebulizer or MDI. They might also need a lung transplant. And then another big thing, chest physiotherapy is done 30 minutes before meals. So it's always done before meals. And then you want to avoid doing chest physiotherapy immediately after eating. So make sure with CF patients that we're doing that chest physiotherapy about 30 minutes before they eat. And then for pancreas interventions, we're going to do replacement of pancreatic enzymes because of the malabsorption issues. And if they're taking enzymes, they have to be given before every meal or snack. Then we also want to do the fat soluble vitamins, so KADE. And then they'll be on a high protein, high calorie diet. So that's basically all for respiratory and HEENT. So if you guys have like any questions about anything that I covered today, just definitely let me know. And yes, thanks for watching my recording. And please scan the QR code. All right, thanks guys.